So hemodynamics, so we're doing all the waveforms and tubes and everything we can get to see how the heart works and also how the body's working, right? Whether the body is clamped down on the outside the heart, right? You can look at SVR. So SVR is one of our things we can look at. We can look at the pressure in the left atrium. That's our pulmonary capillary wedge pressure, which also has like 5 other different names, right? So pulmonary capillary wedge pressure, pulmonary artery occlusive pressure, or wedge, right? So there's many different names for the wedge. And then we're looking at the RA pressures, the right atrial pressures, or your CVP. Okay, so CVP is something we'll look at as well. And we'll be looking at the arterial tracing as well, all right? So arterial tracing is also, of course, what's going on outside the body. All right, and again, you don't have to know all these numbers. These aren't the numbers we're going to want you to walk away with, but we do want you to get familiar with definitely the arterial line, and we'll talk about CVP. CVP is more of a lost art form. It got phased out, luckily, because people are using it for volume status, which it should not be used for, but it has a lot of other great utility, which we'll explain to you. Right, and same thing, the arterial line. Arterial line doesn't just tell you systolic, diastolic, a map. It can tell you fluid balance. It can tell you what someone's SVR is. If you attach it to another fancy machine, it can tell you your cardiac output in real time. Right, so the arterial line gives you a lot of utility as well. And then we'll talk about how you get these, right? How you put an A line in, how you get a CVP, right? If you're a triple lumen catheter, for instance, an A line is an A line. You can't jerry-rig a triple lumen to make an A-line. And then we have our PA pressures, and these are done in yellow because that's with our Swan GANs, which is Dr. Swan and Dr. Gans invented in the 60s. So it's been known as that ever since, because you inflate a balloon to make it flow to the place that it needs to go. So floating a swan, that's gold. You can't get away with that mnemonic right there, right? So, but it's called a PA catheter, a pulmonary artery catheter, because it floats into the pulmonary artery. So we're measuring what's going on right there in the pulmonary artery. Right? So there's a lot of numbers. You may feel a little bit jaded when you come out of this class, but we'll take some breaks, make sure that you are understanding the concepts. All right, so again, what do you need to know? We do know cardiac output, and our last couple slides will go over cardiac output and how to get it, but you can use those as reference, right? Because PA catheters or swans come few and far between, right? So you can pass along. I think this is the broken swan. Is that the broken swan? I can't tell. All right, by the way, these guys are going to be inserted, and you can get your cardiac output from it, okay? So your cardiac output is measurable by your PA caths, and you can also measure it with your A-line. If we have a fancy device like the Cogent monitor or the continuous cardiac output monitor, they can adapt an A-line signal and get you a cardiac output, right? And then, of course, you're familiar with maps and blood pressures, but we'll kind of tell you which blood pressure to trust, whether it be your NIBP, your A-line, or the family across the room, which one's going to tell you which one the actual blood pressure is, and then what a target map should be, and which is and how to verify that this blood pressure is real or not, right? And then SVR, systemic vascular resistance, or total peripheral resistance, or resistance. They have many different names. Usually SVR is usually one we'll be using and coining, but you'll have to know, kind of what the approximate value is, approximately 1,000, right? Everything is plus or minus something, right? So it's 1,000 plus or minus 200. And we'll touch base on SVR towards the end when we talk about swans, right? Or PA catheters. That's what's going to tell you classically what our SVR is and classically what our cardiac output is, right? So in yellow here, these are things you can get from a PA catheter. You can get your PA pressure, your pulmonary capillary wedge pressure, your cardiac output, and your SVR, and a few other things too. You can get stroke work index and all of the fancy stuff. All right, and then A-line is A-line, like I mentioned. And A-line, you can get what's called stroke volume variance or pulse pressure variance, PPV, as well, PPV. And these guys are also a way to assess someone's volume status, but they have to meet the stars have to align. They have to be on volume control. They have to have 8 mLs per kilo. They can't have an open chest. So, but it is something that's useful. Right? And a lot of hemodynamics are invasive. There are newer devices that are non-invasive, like that. An A-line is an invasive measurement, right? But that is not as bad as a PA catheter being right in smack in someone's heart, right? But we do have non-invasive devices. They do correlate, right, where they put it over the neck and the lower abdomen, and it can, I think we have the FICO devices. So those guys, they can be used, right? And again, the thing with hemodynamics is, people like to, they didn't know what they were doing, so they weren't trustworthy values, right? And also, providers would just try to fix the number, and then sometimes the number wasn't even the accurate number in the first place. But at the same time, and then that's why it kind of fell out of favor. The research said it wasn't great. But then, we found there's a lot more utility out of it, and then also the numbers have more meaning now. We're able to, if we get the accurate value, we can then, we can assess what's going on with the patient, because we have to look at the clinical picture and the numerical picture. Because sometimes you do what are called designer hemodynamics. Like, look at my CVP, it's 8. Look at my SVR, it's 1,000. Look at this one, look at this one, and then you'll like titrate your medications up and down, add other medications. You realize, in the end, the patient's like eating breakfast. It's like, we don't need these numbers, right? We'll let them ride. Okay. And then, of course, lastly, we have the CVP. CVP is grabbed from your triple lumen catheter traditionally, but you can also get it off your PA catheter, right? Your PA catheter has a port, many ports, and that's just a basic port that's being passed around right now. That's just your baby swan, right? But there's big swans that even have pacers in it, and a VIP port for the VIPs in the room, right? Is a venous infusion port, right, for the RNs. So there's multiple different things that can be added to this one. Okay, and then also continuous cardiac output can be added to it as well. All right, so we'll know about the different ranges here. You kind of know MAP already. We know arterial pressure, but we talked about O2 delivery at the beginning of our critical care course. You have to deliver oxygen to tissues, you need to have cardiac output, right? So cardiac output is part of it, your O2 stat's part of it, your hemoglobin is part of it. But now we're really focusing on the cardiac output piece, right? What determines cardiac output? Like we talked in hypertension and CHF, what are the two elements? Your heart rate and your stroke volume, right? So when you get really bradycardic, that can start causing issues. When you get really tachycardic, you're not able to fill your heart fast enough, right? And then stroke volume you mentioned, it's like with congestive heart failure, this is kind of where the stroke volume kind of fails, right? But preload can be assessed. That's a component of stroke volume. Good preload is what you need to provide stretch and allow the heart to contract. But too much preload can be too bad. Then there's this, the Frank-Starling curve eventually peters out, and we don't want that to occur. All right, but we can imagine how much preload on the left side with the wedge pressure, the PAOP or the PCWP, and we can also measure the right side with the CVP. So we got the RA and the LA. Those are our two different sides of the heart we can measure. It's like, what's the left heart doing and what's the right heart doing, right? Because the left heart's failing and the right heart's fine, then we got to figure out, what kind of therapies we need to add, or vice versa. Okay, inotropy can be assessed by how hard the heart is contracting. We have different medications we can do to add more squeeze, right? And we'll talk about those in shock coming up in our next few lectures. And then afterload, that we talked about a little bit with CHF, that you want to reduce this in CHF because that you don't want it to work extra hard, right? And that's a function of systolic blood pressure or diastolic blood pressure. Afterload is your diastolic blood pressure, right? That's what the heart has to work again. That's the lowest point in your cardiac cycle, and your heart has to overcome that to eject blood, right? To create a systolic pressure. So, and that's dependent on how squeezed down you are, how vasoconstricted you are, and we can assign a number to that, whether it be 1,000 or 2,000, right? 2,000 is much more squoze than 1,000. Okay. So we can measure SVR, and of course your A-line can give you an idea. When you look at the morphology of the A-line, you can tell if someone is vasoconstricted or vasodilated. Same thing with a SpO2, you can tell the difference. All right, so basic setup. So we're going to talk about some of the setup, how to transduce, supplies you need, how to level it, when to level it, and how to zero it and when to zero it, right? There's many puzzle pieces and things that need to be involved, but it should come, once you do it a couple of times, it kind of makes sense. Oh yeah, I need one of these, I need one of those. All right, so for any invasive pressure, right? If you have a hole in your body, we can transduce it, right? That should be our motto for the ICU, right? So you can put if someone has a Foley catheter in place, let me transduce that, right? Someone has a arterial line, let me transduce that too, right? Someone has a IV in their vein, in their peripheral IV, you can transduce, it's not going to work, right? But you can transduce like a central venous pressure, right? Or a triple lumen catheter. Femoral lines, they work too, as long as they aren't really big and rotund or Rubenesque, right? But to get a pressure or to transduce a hole or a valve or a fluid column, like the arterial column, arterial space or venous space, you have to, again, have a catheter in there. And the catheter has to be placed. Usually it's placed by the provider, right? The arterial lines are placed by the providers, whether it be anesthesia or the ICU. And then we are then attach tubing to it, right? And that tubing is hard. So if you feel the pressure tubing, it feels a lot different than regular tubing, right? So regular tubing is what's spiked into the bag up top, right? Whereas the pressure tubing is very, very hard because we're going to then transduce this fluid column. So we're going to be feeling what's happening inside the patient, right? And that's going to be transduced up to the monitor here. And the monitor is going to convert that mechanical energy into an electrical energy, right? Or electrical signal, I should say. So we don't want that to be lost, over here or over there. We want it to stay within the tubing. And then, of course, we have to have a fluid column at all times. So it's always kind of keeping a pulse on what's happening. We don't want that blood to then back up into the tubing and then clot off, and it's only good for 3 minutes, right? So you need a pressure bag to always be providing pressure down into the orifice, whatever it might be. And that's going to then kind of you get your baseline, and then after that you can then get a waveform off of it, right? It's inflated to 300 millimeters of mercury, so you can get your calisthenics in, right, by trying to inflate this guy, and then you got to make sure you know which way the stopcock goes, right? So otherwise you have to do it again, all right? And then that's going to be infusing saline or at about 3 mLs an hour. So it's pushing here, and we equate how much pressure that's pushing on the saline bag that's inside, and that's be pushed about 3 mLs an hour on average, right? So in 24 hours, that's how much? $72, right? 72 cc's. So that's not that much, but it's still something to consider. 72 cc's every day. I mean, there were some people back in the day who were charting the 3 mLs for their eyes and nose. It's like, okay. I mean, it makes sense in like NICU. It makes sense because 72 cc's is a big deal. But in adults, it's not great. I mean, they can blow that off in 4 hours, right, by diaphoresin. All right, but either way, you got 3 mLs an hour of fluid that is getting put into the patient. And then when you have like a PA catheter, though, you are infusing like 1 bag and 2 bags because you're infusing multiple lines. And now it's like 300 cc's per day. That makes a little more sense. And then to get this signal on the monitor, right, over here, we have to have a cable. So we have little arterial line cables, and these are used for or I should say a pressure cable, because they're used for arterial lines, they're used for CVPs, they're used for PAs, they're used for anything you want to transduce, right? And one plugs into the monitor, and one plugs into the transducer, which we'll zoom in on each one of these supplies. Okay, so the transducer is literally a trampoline. So if you look inside the transducer right there, anybody still have you can move this guy around, right? That one's attached. There's another one coming around here. If you look at the transducer here, right? So the transducer in there, that little black thing is a literal trampoline. So you just kind of zoom in right there. That is a trampoline, right? And there's fluid that's bouncing against it, right? You're applying pressure forward, and then whatever pulsations you get back from the patient are going to be transduced onto this trampoline right here, right? Whatever pressure, whatever it may be. And we know what those waveforms look like, what normal ones look like, what abnormal one looks like, right? So we are going to make sure that that is balanced on the trampoline. If that trampoline is on the floor compared to on the IV pole, obviously you're going to jump a lot harder onto that trampoline. So the level matters, right? So if the trampoline is higher, it's much harder for that pressure to reach all the way up and then bounce on the trampoline, right? We want to make sure that it's nice and level with the patient, right? And where in the patient? It's called the phlebostatic axis, right? So the phlebostatic axis is equivalent to the heart, right? Specifically like the right atrium. So we want to make sure it's leveled there, right? And it needs to be mid-axillary. It doesn't be anterior-axillary. It's not posterior-axillary. It's not brachial, right? It is on the patient. It's being leveled with the patient's phlebostatic axis or the right atrium. So that's why we use IV poles, right? So we got the phlebostatic axis where we level it, and then we zero it because the manufacturer lives in Venice Beach, right? You can walk by Venice Beach, hey, there you are, right? And that's sea level, right? That's what it's not going to give you a value on the monitor because it's going to give you a sea level pressure, right? It's going to be off by it's going to be off by 64 points at least. So we don't want that because 64 points is a big difference, right? So it's not going to give you anything until you actually hit zero on the monitor, and it knows what the beautiful Antelope Valley's atmospheric pressure is, right? So it's equilibrated. Okay, so phlebostatic axis for your cardiovascular pressures. When we have ICPs or we have abdominal pressures, then we level it at different places. Okay, Another thing to point out, and we'll point out another slide as well, is that this pressure bag is for everything except for ICPs. So please don't use pressure bags for ICPs. We're not putting 3 cc's an hour or 100 cc's into someone's brain every 24 hours, right? That is a point where you do not want to do, where it does matter. All right, so if you have access, right, you can use an artery, right? We can transduce an artery, transduce a vein, and you can transduce a bladder, and you can transduce a brain. All right, these are all things you can transduce, and as long as it's leveled and zeroed, you'll get a waveform. Okay, so there's other little pieces to it, like little vamp. There's 2 different varieties of attachments. So I think I have the surgical variety hanging around here somewhere, and we'll point that out if I can't find it to the break. But it'll come to you, and it looks like an arterial. It looks like it's the same setup every single time, except for ICP. It's a little bit of an exception, right? So we'll point that out when we talk about ICPs. All right, and again, that does not use a pressure bag. Okay, all right, yes?
I'll just look at the bottom left right here.
Mm-hmm.
Are we leveling to the stopcock?
It's a good point. So leveling, and we have a slide on leveling, but it needs to be leveled at the air fluid interface. You'll see everybody leveling at the transducer, at the little trampoline there, the black dot. That is not where you level it. You level it at the air fluid interface because that is what you zeroed it at, right? You want, otherwise it's off by 2 centimeters. Like, what is 2 centimeters? It's like 2 points, and that's 2 to 3 points millimeters of mercury. So it does matter. Okay, so it's leveled at the air fluid interface. Okay, but you definitely don't want your trampoline to be too high or too low. So we want to make sure that is nice and leveled where? At the phlebostatic axis, right? And then we'll learn about different stopcocks on here. There's a lot of different stopcocks. Usually on A lines, I think they're all off except for one, right? They want to just make sure you're paying attention, all right? So they have, usually with the tab, usually if you look at the tab and you feel it, it says in Braille off, right? So you can see on there it says off, and then everything else is usually off as well. Again, except for one little tiny exception. Usually it's on the vamp right here. But otherwise, that lets you know where flow is going and what's going to happen if I open this or don't open it, right? Because sometimes you want to have it open to air. So if I want this trampoline open to air, I got to turn it off to here. That way it can see air, right? So it can feel the cool or warm Antelope Valley breeze. All right, so transducer, the trampoline, so zooming on the supplies. All right, so again, it's a very, very dumb device. It's only as smart as the user, right? It only has a little black little trampoline in there. And again, if it's too low or too high, it's going to report back what the number is. It doesn't know that it's too low or too high. It just says, hey, I'm getting this pressure being bounced on me. All right, someone set up a pressure bag being pushed into the patient. Right, it's pushing about 3 cc's an hour. We're going to attach it to anything we can transduce. So in this case, looks like we transduced a PA catheter. It's a weird PA catheter, like a branch. But we transduced that PA catheter. We don't know which lumen it is, if it's the distal lumen or the proximal lumen. So we can't really tell if we're going to get a CVP or a PA pressure or what. But we're going to get something, right? We're transducing the fluid column that it's attached to, right? And then the patient's own impulses are going to bounce via that hard or soft tubing. The hard tubing, right? And then it's going to translate. It's going to literally bounce on this trampoline right here. It's bounce, 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 right? That's what's happening with every pulsation that the patient is giving them, right? And that mechanical energy is converted to, or mechanical signal is converted to electrical signal. So the wire, the gray wire we passed around, that then plugs into the monitor, right? It plugs in right here at the transducer, and so right here there's a little cable right there, right? And it also plugs into the monitor. And then that way we get the signal in the monitor, right? And then we, of course, then interpret what that signal means. And then the other piece is the flush that's going down, right? So there's a little bifurcation, a little fork on the road right there. All right, so that's the idea. So you're bouncing on this trampoline. So if your trampoline is all the way down here, right, that is a lot different than if it's all the way up top, right? So you are literally, if you zoom in on the trampoline, it's just a little, it looks at the change in mechanical energy, and it will get you a waveform, right? The mechanical energy is converted to this resistance, or mechanical energy is converted to a waveform of some sort. Okay, so more gravity equals more jump, more bounce, more pressure, right? So literally 1 centimeter is about 1 millimeter of mercury. That's about how much it is approximately, right? And then 1 inch is about 2.54 centimeters, and equates to about 2 millimeters of mercury. So every 1 inch you're off by about 2 millimeters of mercury, all right? So that's a map of 65 or 63 or 67, right? And as we'll find out, that it does matter if you're radial or you have like a central arterial tracing. Okay, again, this is not the patient's actual pressure, right? It must be leveled, otherwise it's, we don't know where that was, right? Because the monitor just displays a blood pressure. As long as you leveled it, sorry, as long as you zeroed it, it's going to display a pressure. If that trampoline is too low, it's going to bounce super hard onto that trampoline, right? When it comes out of this arterial line right here. So the idea is to make sure that we are, again, level, right? And again, you can transduce anything, just like cranberry juice, it's in everything, right? You got grapes right there, it's cran grape, right? You got oranges, cran orange, right? You have banana, cran banana, right? Cranana. So there was all kinds of things you can transduce, and there's certain important things that we can glean from this information, okay? So again, artery, vein, bladder, brain. Which one of those does not use a pressure bag? Brain. No pressure bag on the brain, no bag, right? And every orifice has a different waveform. All right, some look similar, like the left heart and the right heart have the same exact waveform. They're just sort of kind of displaced a little bit because they occur a little bit later than each other. And also because when we transduce it, we are getting a reflection of the left atrium. So we'll talk about more with PA catheters. All right, so again, 1 inch is equivalent to about 2 millimeters of mercury. That's about how much it weighs. All right, and so your CVP has a waveform, your IAP has a waveform, your ICP has a waveform. Right? What's the CVP of your toes? A normal CVP is about 6 to 10, right, or so. But CVP of your toes is 80 points, right? That's how much gravity is pushing down on your toes, right? So right now, if I'm standing up, if I put a CVP in me, right, and I measure the CVP, and I put the level on the floor, that's the CVP on the floor. Do I care about the CVP on the floor? No, I care about the CVP in the heart because that's what the heart has to deal with. All right, so we're leveling it to the where? The phlebostatic axis right here, letter C, right? And this is my best mnemonic. It's the Ferretti millimeters of mercury, right? That's where you're going to be. You want to make sure that you are leveled with your transducer. All right, so how do you level it, right? Again, with gravity, if you put it down farther, like right down here, we level the transducer right here. How much difference is that? So when they measure on average about 40 centimeters, about 21 inches, right? Every inch is about how many millimeters of mercury? About 2-ish, right? So if that's about 18 inches, 20 inches, we're off by at least 20 points, right? If we have it right there on the ground. And some people will see them have it like taped to the arm, right? And that can slide down to the bed, and you're going to be off by at least 5 to 10 points, right? So we want to make sure that it's on a IV pole and not at too high or not too low. Especially if you like sit the patient up, you want to then, or you raise the bed up, we're going to raise this with them, right? And when you put them down, right, you're going to then make sure we're all leveled before we leave, right? And again, we we level this at the air fluid interface. That is where that's what the monitor knows as the atmospheric pressure, and the transducer is equilibrated to that, right? So phlebostatic axis, where is it at? Fourth intercostal space, midclavicular line, right? That is technically where it's at, but usually it's the mid-axillary line. Okay, and everything is usually leveled there except for the ICP. ICP is measured at the tragus of the ear, and then if you have like intra-abdominal pressure, it's measured the pubic symphysis, right? So pubic symphysis I have down here, right? We're measuring an intra-abdominal pressure, and that has a lot of utility. We'll talk about that in GI, and ICP we'll talk about in neuro, right, where you get it's the same setup. You're just hooking up to a cavity or a fluid column, and you're going to measure the waveforms that are coming off of it, right? Except this does not have one of these pressure bags, right? So here we've leveled our transducer, right? And then we know that this is accurate because we leveled it, and it's going to prompt you to zero it, right? You can't get a number unless you've actually zeroed. The monitor knows this, okay? So we're level here with the phlebostatic axis, and again, this signal that comes from the patient down the hard tubing is going to bounce on this trampoline, and we're then going to get that waveform on the monitor, right? And we keep a fluid column pushing the other direction. Otherwise our line is going to get clotted off, right? Because arterial pressure is what? 120 over 80. You've seen 200 over 120. You've maybe seen like a 240 over 140, right? So 300 millimeters of mercury, nobody has hit 300 just yet, right? So that's why we have it up to 300, right? So it's not going to go any higher than 300. So we're going to be pushing at least 300 millimeters of mercury into the patient. It's nice. It's going to be keeping a tab. So as the patient has a pulsation, you can feel that deflection, and that will be translated up the tubing. Okay. So these are differences in your waveform based on whether you are you're leveled or not leveled, right? So that's the idea behind making sure that we are leveled with the heart and not level with like the arm down here. You can see there's a big difference there. Okay, and that can be the difference between titrating Levophed, right? Levophed is usually titrated a MAP at 65, right? So if you're already getting pressures of, that's a titrated MAP of 55 instead, right? So they could have been getting insult to the kidneys, to the brain, and everything. So we want to make sure that we are accurate. All right, so what are the parts or the supplies for, we're going to put an A-line in, or give me a CVP. So when that happens, you have to know all the different supplies you need. So we kind of been mentioning this. You need a pressure bag, right? You need priming fluids. So the fluids here are the priming fluids that will be flushing into the patient at how many mLs an hour? 3 mLs an hour, or it's going to be pushed. It's going to be pushing at 300 mLs of mercury. And we need that guy right there. We need normal saline, not D5 water, not heparin. All right. The only time you use heparin is for when you have a what? Who remembers from cardiac? Yeah, a sheath in place, right? Remember, a sheath and arterial line are much, much different in size, right? So there was a sheath floating around here somewhere. We'll find him again with the break. So here's a sheath, right? So I'm going to pass that guy along. And then here's an arterial line here, right? So you can see which one needs heparin and which one doesn't. One's much bigger than the other. Okay, so heparin is only for sheaths. And then pressure tubing, right? The tubing that's coming from the patient right here is hard or soft? It's hard tubing, so we're not losing those waveforms that we want to transduce or waveforms we want to investigate, right? And that way, that's the way you can tell like which one's the patient side and which one is the fluid side. Because we feel the other side here, this side is nice and feels like IV tubing, right? Close to the bag, whereas the point of no return is after the transducer. That's where it starts becoming changes from soft tubing to hard tubing, right? So what else? This tubing comes in a bag, right? So this is the bag right here. This is a three-way. This is a fancy one. It's a three-way one, but we have it looks very similar, like this, right? There's the little little bag like this, and it has your pressure tubing inside, right? And it's ready for you to spike a bag. A bag of what? Bag of normal saline, right? And how often do you change bags or tubing? I should say the bag of saline. How often do you change those? Every 24 hours. It does not change. Every medication known to man gets changed every 24 hours, right? Except for a few that get changed more frequently, such as lipids are changed every how often?
12.
Every 12 hours. What about blood tubing? 4 hours, right? Or after 2 units, whatever comes first. All right, so yeah, but then what about, that's the bag, what about the tubing itself? When does that, how often does that get changed? This tubing right here, this pressure tubing, pressure bag tubing. It's the same as IV tubing, which ours policy is every 72. CDC says 96, but we make it 72 so that you arrive at the party on time, all right? So I want to make sure we're changing that every 72. So how do you know that it's trying to change it? You just taste it? Okay, it's been 3 days. How do you know? Charting, maybe, right? But what else? Labeled, right? So the tubing is labeled just like your IVs, and the bag is labeled as well, right? And a pro tip is that you label the bag before you inflate it. Otherwise, you have to deflate it, and then you can try your best to squeeze 300 mLs of mercury out of a label between that mesh and the bagging, right? And then you need a pressure cable. So we got the pressure tubing, we got our bag, we got our saline, and then we need a pressure cable. Who has the pressure cable? All right, so here's our pressure cable as well. All right, and then what else? We need a transducer holder. So it's nothing fancy, it's just a little holder like this. All right, we have plenty of these. We overbought them. So these are the transducer cables. We have to grab the little markers that tell you that's red, yellow, or red. But either way, this will work for you. It's a little deceptive. It looks like it just slides in, but there's actually 2 different levels inside of it when you're kind of put it in there. So you just got to trust the process and push it all the way down, right? It doesn't fit into the top half. It does fit once you push it all the way down. And then you need an IV pull because we're not going to tape it to someone's arm because that's going to get you bad pressures, right? Or inaccurate pressures, I should say. And then maintenance. So maintenance is you got to level it, right? Make sure it's level at all times, especially when you leave the room. All right. If you get a funny number, you're going to go in there and say, I don't trust this, and you make sure, oh, it is level. Shoot. All right. Then maybe I need to intervene. And then we need to make sure it's zeroed. That's just on arrival. And then drawing blood. So there's a process for drawing blood out of the A-lines, right? It's the same thing as drawing blood out of a CVP if you had this hooked up to a CVP as well. Okay, so we got a pressure bag, we got our saline, we got the pressure tubing, we got our pressure cable, and our transducer holder, right? What is this right here? The bottom left.
Looks like
That's our pressure tubing that has the spike in it, where we're going to spike into our bag right there, right? If you notice all saline bags, you've never used them before, maybe you've used it to mix medications, they have another little port right here. So you can put 2 hemodynamic monitors into this, right? You can use 2 pressure tubings to do it, right? Because 3 mLs an hour, that's what, 72 cc's in 24 hours. You have to change every 24 hours anyways. So a 250 bag is plenty for two setups, right? If both are pushing at 3 mLs an hour, you're going to have plenty of saline to go, okay? All right, what else? So we remember our transducer. This, again, remember, is called our vamp. That's just a way to keep avoid infection, because with the OR style, it doesn't have this syringe in a closed system. So you have to attach another syringe every single time, which can introduce infection into the line. So we have these vamp systems that maintain sterility. So you only have to then you pull it back, all the fluid back, right? So here's the patient over here, right? So here's the patient right here. We're going to pull all the blood in here. It's going to fill up with blood, fill up with blood, fill up with blood, and then we attach our syringe and draw our sample. Instead, before, you have to wipe the port down, you have to draw back your waste, discard your waste, and then attach another syringe, and did you wipe it? I don't know. And then you have to then pull back your sample, discard it, and then you have to flush it again. It's a whole process, right? So it's easier when we have the vamp in place as well. Okay. So the pressure bag. All right, so our pressure bag is inflated to how high? 300 millimeters of mercury, and it's what fluid? Lactated ringers? No, normal saline, right? So normal saline is being infused, and again, we have 2 different ports at the bottom there that we can use to plug in, right? And if it's a 3 mLs an hour, you can calculate that 250 is more than adequate, right? So pressure bag must be checked, right? You have to ensure it's pushing at 300. So is this guy right here up to 300? No. So if you pull it up, you can see the little green zone. That's where you know you're at 300, right? So a little green zone there. The red zone doesn't matter. I don't think it's going to pop on you, but as long as you're at least the green zone, right? If you're in the white zone there, you're not putting enough pressure on the line, and it can clot off on you, right? So the blood pressure is more than what you're pushing in. Like if it's an arterial line, that can cause a line that's not going to work great, okay? As flush solution decreases, that can also change the pressure of the bag, right? So you need to be cognizant of that when you go in to make sure you're at the green, right? You're in the green zone. And then what else? So when you are done with inflating, right? You went through your arm exercises, you inflated all the way up, right? You got to make sure the stopcock here is turned to the right position, or the correct position, I should say, right? So what is the correct position? This is an off tab. It says off on it right here. So where should it be off? I want to make sure that the air stays in the bag, right? So I'm going to turn it off to the bag. That way, if the air tries to leave, right, it's going to then come down, and it's going to then hit that off switch right there. If I kept the off switch in its neutral position off to the left over here, or off to the side, then it will slowly leak back into the cuff right here and out the hole at the bottom, right? So then you're going to lose pressure in your bag. So we want to make sure that we have our switch turned off to the bag, right? So if I kept it just facing that way like you did by default, all the air would then just kind of leave the bottom hole right there. You may have seen on TikTok or other little tips and tricks, you can use the air meter and inflate this rapidly. That's perfectly fine. It's going to shh, and you're done, right? You look like you can do like balloon animals next, okay? All right, so then what else? So make sure your stopcock is appropriate. You're going to label the solution before you inflate, right? We're going to make sure we are using normal saline, but sometimes you might need to use heparin. When do you need to use heparin? When you have a sheath in place. And how much heparin? Enough is the right answer, but not too much, because too much is the regular intravenous form of heparin. If we're giving like an IV heparin drip, that's too much, right? So we're going to make sure we're at 2 units per cc. All right, so we're going to make sure you're calling down to pharmacy and they bring that up to you, okay? Because they don't stock that routinely in the kit, in the bins, okay? If everyone was on heparin like they were before, then everybody's going to be at risk for heparin-induced thrombocytopenia or heparin allergy, right? And fluid bag is changed how often? Every 24 hours. That way we are not introducing more infection into the patient, right? And again, 250 bag is more than adequate. And again, you can have up to 2 lines plugged into our bag itself, right? So there's a complicated setup over here, right? We got our 3 different transducers there, right? So our bag right here is using one of these fancy three-way pressure tubing. So it has 3 different transducers on it, and it has one spike, right? So the one spike is getting fluid from the bag, and all of that is flushing into the patient, right? At different parts right there. This is a PA catheter, and it's flushing into one lumen, another lumen, and also the arterial line. So we're putting pressure on the patient's patient's fluid columns, the venous column and the arterial column, right? So the other piece is that we need to see what happens when the patient has has waveforms coming up these tubings, right? So that's going to be translated where? Translated from the blue to an electrical signal onto the monitor, and it gets plugged in, and then we have to choose the correct label, otherwise you don't know which one it is, right? So when we plug it in, we choose the right labels. Hey, this is my arterial line, and then the next one, plug it in, this is my CVP, plug the next one in, this is my PA pressure, for instance, right? So again, we're providing about 300 millimeters of mercury on the patient right there. So you can see, Mr. Ian Malcolm is breathing there, right? That's the patient's pressure. And then we are on there just feeling it, right? We're saying, oh, going in and out, whether it be an arterial line tracing, a CVP tracing, or a intra-abdominal pressure tracing. The only difference between an ICP and this is that we're not using a pressure bag, right? Everything else, you will use a pressure bag. And how you know your pressure bag's at 300? It's in the green zone, right? All right, the tubing itself, right? The tubing is hard to the touch. Otherwise, the pressure will be lost on its way back to the monitor, right? So we want to make sure we're not losing any of that valuable information, okay? And how do you prime it? The way you prime it is to make sure there's no air in the system. So you spike the bags. Usually you want to burp it a little bit, burp all the air out, and then hang it up. And then there's a little stopcock on here, or not a stopcock, a little pigtail. But then we'll let you push the fluid all the way through the system, right? The recommendation is to do it before you inflate it, because if you inflate it, it can introduce bubbles. So you prime the whole thing, and then you're going to inflate up your pressure bag, right? So place flush bag in there, priming it by pulling a little pigtail right here, and there's what are called fenestrated caps, right? So there's fenestrated caps and non-fenestrated caps. What does fenestration mean? What's here? Okay. Fenestrated caps at. What does fenestrated mean? If you want to defenestrate someone, you throw them out the window, right? That's what they do in Russia, right? You defenestrate somebody, that's an open hole, right? So fenestrated means whole or holy, and then there's the non-holy one, or the unholy, right? So we have the unholy caps and we have the holy caps, right? So this is unholy. This comes in the kit, and this one comes in on the line itself, right? So this is the fenestrated one. So you can see the difference on those two, right? So these guys are used to, the reason why you have the holy one is so that you can flush the whole tubing, right? So you flush it out, that little holy tubing there, the hole in the cap, and then that little side port is flushed, and then we turn off our little stopcock there so that we can then flush the rest of the catheter all the way through, right? And then at the very end there, it has a hole in it, and then we are able to then take it off. And when we attach it to our line, it's going to be wet to wet. So there's going to be a little fluid with water tension at the end of it, and you're going to attach it to them with water tension as well. So it's wet to wet attachment. But in the meantime, this guy has a hole in it. But oftentimes you're going to find people that have not changed the hole on the side. And why is that an issue? On not changing the fenestrated caps to non-fenestrated. Yeah, so infections can get into that little hole, right? So we want to make sure that we're changing all these little fenestrated caps, or this is a gray in color, to a non-fenestrated, or to one that is dead-ended, right? So are these fenestrated or non-fenestrated on the bottom right there? What do you think they are? So they are clear, right? So if they're clear, they are going to be what? This brand is fenestrated if they're clear, right? So the white caps are the ones that have no hole in it, or are unholy, I should say. Okay. All right. So anyways, we're going to make sure we prime the whole thing, and then also you want to program, flush your syringe as well. So that's something to consider when you have a vamp. The syringe has a little bit of air space in it that we want to prime. Okay. And how do you connect it to the patient? If you're going to connect it, they're ready to go. Want to give me the pressure tubing? It's connected in what fashion? It's connected wet to wet, right? So here's the A line they just inserted, and has a little fluid column or a little fluid water tension there, and we're going to go ahead and attach ours wet to wet, right? We'll make sure that we are going to bring our little solution. It has a little, and we can flush it a little bit so that it has a little water tension at the end, right? So fluid to fluid or wet to wet, right? There shouldn't be any air being introduced there. And the last step, again, is replacing the caps. So make sure all the caps are replaced with the unholy caps, right? Not the holy ones. All right, comes holy, and you have to unholy it. All right, so the pressure cable. All right, so you have to grab a pressure cable. Otherwise, all you're doing is, pushing 3 cc's an hour into the patient, right? So you plug your cable into the transducer. So your transducer has a little cable at the end there, right? Different companies have a different variety of attachment. So all of ours use the same one. And this is going to then plug into the transducer at the end over here, right? So we got our transducer plugged in right there. And then we're going to then plug the other end of the gray cable. What's that? Someone's getting dial up over here. Anyway, so you plug in a cable, right, into the transducer right there, and the other end's plugged into the monitor, right? So it plugs in right there on the monitor. You can see at the red end, so the red end, that's our pressure cable. And then there's only 2 pressure inputs on our monitors. So what the heck? What if I have a PA catheter and I want to get an arterial line, a CVP, and an A line? What do I do? There's such things called a splitter, right? So we got little splitters out there as well. I'm going to pass that guy around. So the splitter is something that can split, and you can split twice, right? So you can get like 4 on one lumen here, right? Or one input. Okay. And then the other label P1, P2, or P3, P4. It doesn't really matter which one you plug in. I think there's a default one. Like if you plug it in, you'll get A line every time. I can't remember which one it is. You just got to make sure you select the correct label on the screen there, right? So once you plug it in, it will then pop open. It might show a CVP tracing. It might show a PA tracing. It might be a white tracing, like an ICP, or even a general pressure tracing. You just got to go down to the settings and select ART from the menu there if it's an arterial line, right? What else? So you select the correct label, and then you can zero the monitor, right? Let the monitor know that you are in the Antelope Valley currently and not in Venice Beach, right? Or you're not on Mount Everest, for instance, or not in a helicopter, because on the helicopter, I think they have to recalibrate like every 5,000 feet or something like that, right? So you want to make sure that you are letting the monitor know what is where we are right now. What is the millimeters of mercury outside that transducer currently? So do you need a patient attached? No, you don't. All you're doing is telling the monitor where you are, right? You can zero a line or a CVP or a P line without the patient even there, right? They say, hey, we're going to set up for an A line. You can do all this stuff first. Once the A line goes in, you just attach it, and boom, you got a waveform on the monitor. Okay. So what else? So we're going to make sure that we are, and then when the patient does get attached, then that's when you would level it, right? You would level it after that. But the zeroing piece is only zeroed once, right? And it is zeroed once, but it's also zeroed at without the patient present, right? You can do it with the patient present. No one's going to fault you for that. Okay. So that's the idea behind these, behind the pressure cable. Let's plug it in where, right? If you look at the transducer, you follow it back. One is going to the pressure bag, and one is going to a little port that's going to be where you can plug in your pressure cable. Okay, so zeroing. This isn't leveling, this is zeroing, right? So leveling is what? To the phlebostatic axis if it's a cardiovascular pressure, right? So you're leveling there. But zeroing just means you're telling it that you are right here, right? At 696 millimeters of mercury. You're not at 760 at Venice Beach, you're at 696, right? That's off by 64 points, right? You don't want to get a waveform on your monitor that's 64 points off, right? So the monitor's not going to give you a number until you zero it, right? The factory default is 760, right? So you must zero before use. So do you need the patient present or not? You do not, right? Lovely, need the patient present? Yeah, I mean, you can get a little dummy standing, I guess, and say this is where the phlebostatic axis might be, right? But you need to have the patient present for leveling. You don't need it for zeroing, right? And when do you have to do zeroing? Once, right? There used to be what's called pressure drift. What happened on the older monitors where it would drift by 3 points every day. That's been phased out with the GE monitors and new monitors nowadays. They don't do that. So every shift, some people do that because they don't trust the nurse in front of them, right? So they might do that, or they might get a good flush, and there might be some reasons why they do it, but it's not absolutely necessary. Once it's zeroed, then it is done. The only time we have to re-zero it is if you unplug the cable. Then now it refreshes back to the factory settings. So if you unplug it from the monitor or you unplug it from the input on the transducer, then yes, now you have to re-zero it, right? Because it defaults back to its factory settings, right? So how do you zero a patient, right? So do you have to be leveled if levostatic axis to 0? No, because the patient doesn't even need to be there. Why would they need to? But also, it doesn't. All you're doing is telling the transducer what the outside pressure is, right? And then once you hook it up to the monitor and level it, that's when you get your actual pressures, right? So first step, you're going to open the transducer to air, and that's usually there's all kinds of mnemonics out there. It's like I turn right to the patient and left to the left to the bag. That doesn't matter. Look at your thing. It says off on it, right? And who needs to see air? The patient or the transducer? The transducer, which is the little black thing right there, right? You want this black thing to see air, right? If I turn it the other way, would it see air? No, right? And its default position is where? The default position is like this, up to that little opening, right? So that when the patient sends a pressure up to the monitor, it transduces and goes to the monitor. The other half is to our saline bag, right? So that little transducer there needs to be turned so it needs to see air, right? So how does it see air? There's an off tab right here, right? So we're going to turn it to the off so that the transducers can see air, right? Oftentimes I don't even know the mnemonic of how you would, another way you can feel it is like where the soft tubing is and where the hard tubing is, right? This is hard tubing right there, right? You're going to turn it off to the patient. I mean, sometimes you might get a random transducer that has been flipped on you. Either way, you want to make sure that it is open to air so it can see air. And now the monitor is going to prompt you to press 0. So you got to find somewhere in the monitor where it says 0, right? So in the settings here, you can hit the arterial label, and you can press, and it'll see 0 there. So 0 art or 0 CVP or 0 line. You press that, and then it does its thing, and you'll see 0, 0 on the monitor, right? If it's an ICP, it'll say 0 because there's no diastolic ICP, right? If it's an intra-abdominal pressure, it'll just be an actual number, right? But otherwise, with a arterial pressure, PA pressure, you'll see like 0 over 0, for instance, and that's how you know it has been zeroed, right? There's another button on here that says 0 all. Also on the wall, on the actual physical monitor, there's a 0 all button. You can use that as well. Okay, and then when you're done, you're going to turn it back to flow. So which direction will you turn it? Where's its default position for this little off switch here? It's going to be off over here, right? That way you have flow going left to right, right? So we have flow going this way, right? Line. So when you have an A line, this works for a CVP as well, right? These are all the steps here. You need to grab a syringe with a little adapter here. So if you look, there's a syringe, is actually the balloon syringe, but any syringe will do that's lure locked, right? Even a non-lure locked one, like an A line, that can work as well, or A line, arterial blood gas sampling tubing or syringe can also work. With this little adapter we're going to grab, stocked for us. It's a needleless adapter because we can't be trusted with needles, right? Because we'll poke ourselves inevitably. So we have the little needleless adapter, and it goes onto this little port right here that's closest to the patient, right? There's 2 ports there, so you can really choose either one. The important piece is that you pull back enough blood for waste. Just like if you pulled a central line, if you're on labs with central line, you got to pull like 10 cc's of waste, right? It's the same thing, but you don't have to discard the 10 cc's because it's in a sterile system, right? So first step, grab your supplies. Next step, you're going to open it up, right? Where do you want to open it to? Do you want to turn it off to the patient or off to the transducer? So off to the transducer because we want to sample from the patient, not from the transducer, right? So we pull back all this blood into this tubing here. We want to make sure that we're not pulling from this diluted with saline blood. We want to make sure we get a nice clean sample from the patient itself, right? So third step, you pull back on this syringe right here. It's going to pull back about 14 cc's, and then you're going to turn it off. And unfortunately, it's not the tabs on this little doohickey right here don't say off. It's different, right? But it's kind of the same that if you I should say, they are not, when they are in line with the tubing, that's flow. So that's the little tricky piece with that little guy right there. And you'll find out real quick, because when you try to return the blood, it won't return, right? So you realize that the stopcock up here in the corner, it needs to be turned to be parallel with the tubing. Okay. All right. So we withdrew blood into our tubing, into our vamp. All right. We got our adapter ready to go. All right. And then sometimes you might have an OR system, and really you should be changing that OR A-line system to our own, because again, there's the risk of infection. It's going to come out in 4 hours. Sure, you can keep it in and then we'll take it out. But if it's going to stay there overnight, then we should be changing it to which kind of system? This one that has a vamp, right? And it's a closed system, right? And then we turn it off once we pull it up, all the blood, we're going to turn it off either right here or up top is another option. And then we're now going to be able to draw our blood from the patient, right? And then we draw our sample. Before we draw the sample, we got to make sure we wipe it, right? Did you scrub the hub? All right, you wipe it, foo. All right, that's the way that we make sure we avoid any kind of introduction of infection. Okay, and once we got our sample, we're going to make sure we return the blood. Otherwise, what will happen if we don't return the blood? What if all the blood is still in the tubing? It's going to clot off, right? You have about 3 minutes or so before that clots off on you. So you want to make sure that all of this is infused in. So how you know it's all that blood's been infused in? It'll be clear, right? Because it'll be red and then pink and then clear, right? So once it's clear, you can watch it. You can see it going in, going in, going in, and then then you give it another extra 2 seconds of flush, right? How do you flush it? You can use the syringe, but we have again that little pigtail right there that we pull, and that will push the fluid in, right? Because what's behind the pigtail is 300 millimeters of mercury. That's going to be flushed in, right? And then make sure after we flushed it, the other piece you want to make sure before you leave the room is that you have a waveform on the monitor, right? That waveform is flat or dampened or not there. That's not good. It needs to have a waveform on the monitor before you leave the room, before you say that you're done.